Haven't got any questions today from members of the public, have we, Granny?
No, none have come through to me.
Okay, Granny, do you want to turn on the recording?
Joe, are you picking that up? Or are we just recording it rather than streaming? I didn't know there was a change of plan.
Okay, whatever we're doing, can we start?
The streaming's running okay, Russell, so okay. It's fine at this end.
Okay, super. Well, welcome, ladies and gentlemen, to this, the July Board of Worcestershire Acute. We as a board have had a busy morning already, talking about some of the learnings that we continue to make on areas where we can improve. I had an interesting patient story where for a child with special needs, we hadn't handled things as well as we could have done. And we had a good discussion about that in terms of learnings for the future, and a really good session on urgent and emergency care and the transformation programme, which Sarah Shingler has been leading to try and improve across a whole broad canvas of different areas the performance of UEC. So thank you, Sarah, for your leadership on that. So without further ado, we will get going into our board. So we have apologies for absence from Michelle Lynch, Catherine Driscoll and Justine Jeffrey. I don't think we've got any other apologies, have we, Joe? So declarations of interest. Are there any declarations of interest, colleagues, that you'd like to mention? Simon?
Thanks, Russell. Just to inform the board, I have joined the foundation of the Worcester City Women's Football Club. This is a pro bono position to promote football for women and girls in Worcester and beyond in the county for health and wellbeing purposes. So I'd just like that registered, please. And I'll fill in the appropriate form as well for you, Joe and Gwenny.
Thank you, Simon. Any other declarations of interest? Okay, so the last set of minutes held on the 10th of June. If you're unhappy with the accuracy of those minutes, could you raise a digital hand for me, please? Simon?
Apologies, Russell, me again. Right at the very end, there's a reference to a comment I made about the Wudu facility for Muslim staff at the Royal.
Yes.
It says appropriate staff, appropriate facility for Muslim staff. I think it would be more accurate to mention Wudu specifically. If that minor amendment can be made, please.
Okay, of course. Thank you for that clarification, Simon. Any other points of accuracy? Okay, so in terms of actions arising, there was just one which related to the IPR and the proportion of estate vacancies to be shared with the board, and we were updated on that. So thank you for that, Ali. Any other points on matters arising which colleagues feel I've missed? Okay, super. So without further ado, an awful lot going on at the moment in the NHS, Stephen. Could you provide your summary for us all, please?
Yeah, so obviously at the time of writing and submitting the report, we were awaiting the 10-year plan, which we've now had. We will do more in depth at future boards around that. There's quite a lot in there for us to digest. And my couple of observations at the start, though, is there is an awful lot of it that already fits with the strategic direction of the trust. So we already kind of had an idea of where it was going to go. I think the two bits that come out of it and linking for the board agenda and the development session we have is really around the pace and performance that we get to get ourselves in the best position to take advantage of some of those things in the 10-year plan that will come through. So we'll continue to, so we'll update on that. The other bit, as you said, there's an awful lot going on. So what I pulled out was the new National Urgent and Emergency Care Plan. And I've put in there just kind of more in bullet points, but just to keep it really concise around what the ask in that plan is. And we are going through that in terms of how we compare to that, to where, and the performance trajectories we need to hit to achieve that standard. Building on the board workshop that we had, it was really pleasing to see at the workshop the work that we're doing around with public health and partners around vaccination, so being ahead of that. So again, I think there's a bit of a theme coming through, we're ahead of it. I think we just need to start seeing the numbers move to where we need them to be. We will bring through a winter plan, and I reference what is expected in that winter plan, and we'll bring that through by summer. So probably the latest will be the September board, because we've got a foundation group board and then that, so we'll bring it through. But just to assure board members, there's plenty of opportunity, and we probably will use those committees such as Quality Committee, Finance Recovery Board, to keep bringing stuff through so that people are cited on it, and the September's more of a final one for that. We are doing that winter plan as part of a system, and I think that's really important, and again links to the plans that we've got around reducing the occupancy and length of stay in both hospitals that we need to do with our community partner. There's some strength and leadership arrangements for a winter director within each organisation and the system, and Chris will be taking on that for us. So Chris will lead us through the whole winter planning process. And I think, and I'd welcome it, I think we've done it, but I think it would be helpful to see as a system those escalation triggers as well. So as demand rises up, what do we all do about it, and being really clear about that. The other bit I wanted to draw out is there's been a lot of attention, rightly really, around maternity services, and in particular those services where it doesn't go as well as we would want it to. So there's a rapid independent investigation being instituted by the Secretary of State in that, and I think there's been a lot of media around some of the, I think there's 10 trusts that have been that are going to be a focus for some of that. But what's come through, and there's been national calls with chief executives around what the kind of themes that are coming out from it, and I just want to draw board's attention to that. So I pull out some of the concerns that are consistent in all of those areas where maternity services are and when we want. Failures in listening to women and family. I think one of the things it might be good for us to draw out in some way is around the kind of inequalities that can arrive around maternity services, so particularly socioeconomic inequality and diverse heritage inequalities. So maybe we do a bit of work where we apply that to Worcestershire and see where those areas are, so we can just assure ourselves on that. And then there's a lot around culture and safety, but I think obviously with the work that Justine and the team in Women's and Children's have led, I think we feel sighted on that as a board, but it's again just one of those areas to just keep a cross-check on. Another focus was around temporary staffing, which is a big area for us, particularly in terms of our agency spend, and around the target that most trusts have around 2 to 3%, we're higher than that at 8%. So this very much focuses in on what we're doing, but I guess it just means we might get some added scrutiny as we continue to bear down on that spend. And then finally, it's just pulling out some of the work that the teams have been doing. There was an absolutely brilliant volunteers week. A number of us had the pleasure of meeting the volunteers and at some of the events that were around. And I've pulled out some of the key ones really that I think really deserve mention, and in particular the discharge response volunteer service. So an awful lot of feedback on that that's just brilliant. And it's an area that we really, really do need to kind of get behind and push. And I know Sarah and others have done that, Simon, have been really supportive around that, but they're a key provision of the trust, really. So just want to highlight that. Congratulations to our research team that have been involved in some UK trials around leukemia treatment, which looks really fantastic. And in terms of research is one of those areas we've talked about with the foundation group about how we really get behind it. It can be, I think it really energises clinical staff. It can be a really good thing for the trust, and we want to be at the forefront of a lot of that innovation. So I think that's something we've really got to get behind, but good to see the work that we've got going on there. And then finally, we had a presentation this morning from Public Health. So again, into that population health management left shift, the work that we're doing around the tobacco dependency programme, and really trying to that kind of make every contact count and what we can do to improve the health overall, not just those very specific things we do as an acute trust, is really, really important. So some absolutely brilliant work that we've got going on there as well. That's what I wanted to draw out, Chair. Happy to take any questions.
Great summary. Thank you, Stephen. Awful lot going on. Questions and perspectives on Stephen's Chief Executive report. Colin.
Thank you, Chair. Stephen, bearing in mind your comments about the importance of collaborating on public health management, and in that regard, the ability for us to be able to share data, I was wondering what your perspective is on how well placed we are around the item in the 10-year plan on digital and data, in particular the federated data platform.
So I think we're in an increasingly improving position, particularly with, if I look internally, start internally and then we'll spread it out. So even internally, we've had issues where we've all been on different systems and you can't see stuff. So I think the work Rebecca and team have done around Sunrise is clearly starting to have a benefit for us. So I think that's the first thing. I think there is still a lot more we have to do with partners. And it's the one thing the public really struggle to understand, isn't it? I can go to my GP, they're on one system, I then go to a community service, they're on another, they're on another, they're on another. I think there's an awful lot we've got to do in that. Chris, I know, has been in active conversations with Rebecca and also with Andy, the Chief Operating Officer at Wye Valley, about how we really start to accelerate the use of the federated data platform, and actually where that leaves us with kind of how we pull information and how we use it. So I think that's one that will accelerate through the next few months that you'll see, Colin, particularly around some of the elective data, where we're looking at things like having a shared waiting list between the two trusts and things like that.
Great. Thank you, Stephen. Thank you, Colin. Simon?
I think you're on mute, Simon. Sorry.
Yeah.
Only the second time I've done it today. This may be one more for Chris than you, Stephen. With the winter plan, different times urgent treatment centre has been mentioned, not least of which by NHS England when they came to see our last winter plan in November. I just wonder where that might potentially fit into what we've got thinking now through for what we'll do in the forthcoming winter.
Yeah.
Chris, do you want to come in on that?
Thanks, Simon, for the question. So we originally submitted a bid for some funding to develop a specific urgent treatment centre on the Worcestershire Royal site. Given the way Capital was working, we were unable to pursue that option. However, what we've done with the teams internally is look at how we can take activity out of our current emergency department and co-locate it with the same day emergency care services we've got in the old emergency department, and the teams are actively working up a plan to create what I'm calling a multi-specialty treatment centre in the old emergency department that will bring the GP and ED and elements of the minors stream out of our emergency department and create a quasi-UTC in the old emergency department. The plans are due with me this time next week for rapid implementation after that. So we've got something as part of our winter plan.
Okay, keep us briefed on that, Chris, so we can all go and have a goosey at it, please. And Karen?
Thank you, Chair. I wanted to go back to the prevention programme and the tobacco dependency, but also first on prevention, just commend the organisation, I don't know if it's Comms or whoever, on the heart failure podcast. I haven't seen any organisations do that, and I did listen to it, and I thought it was really, really good. So commend people for that. But just on the tobacco one, obviously it's been a really successful programme in terms of the cessation, but I wanted to understand if that offering was available to staff. I mean, like all hospital trusts, we continue to see staff thinking they're hiding when they're not, smoking on the trust sites, which is troubling to say the least, particularly you know, when in uniform, and I wondered if the cessation programme was available to staff as well.
I don't know if Ali wants to come in, because Ali was leading a particular piece. There you go. A particular piece of work for us.
I mind. Thank you. So it isn't available to staff at the moment. However, we do have a smoking cessation working group that's looking at how we try and tackle the problem of smoking on site, knowing that it is a sensitive issue for members of the public as well as our own staff and patients. And our smoking dependency lead is actually part of that group as well. So it is something we're exploring. Clearly, it would need to come with some sort of financial solution in terms of how we make that viable and accessible for staff as well, rather than just inpatients as it is at the moment.
Okay, super. Don't want to run down a rabbit warren on this one, but it's just worth remembering, members of the public, that smoking costs the NHS about £2.5 billion a year. Alcohol costs the NHS, in terms of treating people with alcoholism, about £3 billion a year. But obesity and obesity-related illnesses cost the NHS about £12 billion a year. So a big opportunity for health and well-being on obesity in particular, but we'll discuss that on another day. So if there are no other questions to Stephen, clearly, Stephen, you didn't mention that we've just heard the news that the junior doctors have threatened industrial action again. And I would just like to say that whatever the grievance is in terms of remuneration, the consequences on the citizens of Worcestershire of further industrial action will be substantial and harmful. Therefore it's a real disappointment here that a decision has been made. We'll move on then to the integrated performance report. And Stephen, do you want to do the introduction on this, and then we'll move into the detail with colleagues, please?
Yes, so again, following on from the report, one of the main operational challenges in terms of quality and money is around our urgent and emergency care and unplanned care pathways, and I'm sure Chris will talk a lot around that. Some of the other challenges that we've had are particularly around in cancer with our capacity around oncology, but also our pathways that rely on tertiary partners. So the executives are spending an awful lot of time on that and working with specialised commissioning and the ICB around strengthening and looking for different solutions to that. One of the other themes that does come through when you look at all of those areas is around our offer around frailty. And given the population that we serve, we're clearly not getting this right. And there's an awful lot of work going into really getting the workforce and getting the pathways that we need and delivering in a manner that we need them. So they're the kind of main areas that I wanted to, and I think people will pull out the main themes. It's been a particularly challenging start to the financial year, as I've drawn out, but I think we're starting to see things move through a bit now. And as we heard this morning, particularly around the urgent and emergency care pathways, there's an awful lot of work that people are doing to change that outcome, but we really need to start it bedding in and delivering those, delivering the patient's experience that we need and the numbers that we need as a trust.
Super. Colleagues, happy to move into the detail as we're going to cover it. So, Chris, in terms of the engine room, how are you seeing things in terms of operational performance, please?
Thanks, Chair. So a few bits just to draw board's attention to. I will start with elective care, if I may. So from a referral and treatment point of view, we are broadly in line with where we said we would be in terms of the annual planning commitments. Though I am still concerned about 65 weeks. It's yesterday's business and we're still doing some of it today. More work we absolutely need to do to improve in that. And we haven't yet delivered the commitment to get to zero. At the moment, there are broadly 3 specialties contributing to that. But actually, for 2 of those, for general surgery and for oral and maxillofacial surgery, we do have plans that should see zero or very near to zero delivered in August. And there's a higher level of confidence around that. But the one of concern is around ear, nose and throat, or ENT services, where we are seeing significant challenges around getting below 65 weeks in terms of us meeting that maximum waiting time standard, and the work towards 52, and ultimately the work towards delivering 18-week standard in line with the constitutional standards that we should be delivering for our patients. So that makes, so some of their challenges relate to paediatrics, and they are doing some specific actions around how they can support high volume lists with the support of the theatre teams, and issues around other special subspecialty services. There is some pathway redesign work. Their theatre utilisation broadly is 80% overall, but there is some variation between clinicians in there that the teams are working to understand and to resolve, and also to increase the number of cases per list. But I think overall there's more we need to do. So I have said that we will need to have a conversation directly with the relevant clinical director about what else that clinical team can do to work differently in there. Overall, though, in terms of work we can do with ENT, who also have the highest number of patients waiting a first outpatient appointment who are undated, there's some work we're trying to explore in terms of how we can do something different in line with the work from the 10-year plan around upfront work with companies around AI solutions that can really look at streaming out those patients that we don't actually physically need to see in hospital, and how we can make sure that patients don't need to attend our hospitals unless they absolutely need to see one of our team directly. So there'll be more on that in due course, and clearly it will go through the appropriate approvals and governance processes before we do anything. But it's exciting that we could be at the forefront of some of that work from an elective point of view. Touching on cancer, I think Stephen's picked up the two bits that are of most concern to me are around the work for gynae oncology in terms of the commissioned service or lack of commissioned service for a cohort of patients, and our teams are working really proactively to find solutions for patients on a individual patient basis, as well as engaging with specialist commissioning and other colleagues around what other teams, what else we can do around finding a permanent solution, because that is activity we do not have the skill set and are not commissioned to provide in Worcestershire Acute. But at the moment, we're having to manage those patients as best we can while we find solutions for those. And clearly, oncology is a concern because it impacts on almost every cancer pathway in terms of us getting a resolution around, do we have sufficient capacity commissioned to meet the level of demand that we are seeing and evidence that we've seen. Again, I'm concerned about our ongoing ability to meet performance standards in that area. That said, there are absolutely some things we need to get on top of internally. You'll see from the pack that our 28-day faster diagnosis standard has deteriorated again. What I can say is the early indications from June, which is an unvalidated position, are more positive, and generally we see that position improve through validation. But I am still concerned that we've had to take some extreme actions in terms of what breast surgery have called a mega clinic, and what we still need to do in terms of resolving the position overall for skin in terms of that pathway sustainably. Though on that, we have managed to appoint 3 trust locum dermatology consultants in the last couple of weeks, which is a good step in terms of us building the basis of a dermatology service within Worcestershire Acute. And we'll continue to work clearly with our partners at Wye Valley in terms of what that service might look like into the future. But exciting times, I think, in terms of where we have been with that service, in terms of some green shoots, I think is the positive way to look at that. That does then bring me to urgent and emergency care. We have seen high attendances in May, and we saw one day with over 550 attendances across our 2 sites, which is significant, with over 300 attendances on the Worcestershire Royal site. We have improved on our overall emergency access standard, and the overall position is above what we said we would be at this point. So in terms of doing what we said we would do around the annual plan submission, we are above what we said we would do, but what we said we would do isn't good enough for what our patients deserve and what our clinical teams want to deliver. We've seen a reduction in patients over 12 hours. We've seen significant improvements on 45-minute handovers, 72% at Worcester Royal. But I do want to give a big shout out to the work that the Alex team are doing. So the Alex team are handing over 90% of patients within 45 minutes. Frequently, that's 100%. They're also triaging routinely now over 90% of patients within 15 minutes. So some significant improvements, and those are sustained for weeks now in terms of those levels of performance, particularly at the Alex. So just massive thanks to the Alex for what they're doing for our patients and sustaining that. But more work to do on time to be seen, and we're working with the teams around their specific actions in the department about that. We heard this morning about a lot of the big interventions and the big transformation work that we're doing with partners, and we do still have emergency care intensive support, team support, ESIST support to the organisation and to the system as part of being in Tier 1. So that is supporting us with the frailty work, with hospital at home, and with some of our emergency department processes. And they're visiting us again on the 16th of July as part of that work. I guess the other bit of good news, what I see as good news, is year on year, the number of discharges we saw in month has gone up by over 300 compared to the same month last year, on broadly the same bed base. So it's not that we've grown the bed base that much, and driven mostly by Pathway Zero discharges that we've done ourselves, which is again positive in terms of the work that we keep asking our teams to do, and they are doing some of that work. Just lastly then, just two bits then from me. Winter planning is most certainly underway. There is lots of activity in terms of what winter planning will look like, and there will be an update to Foundation Group Board Chair as part of the work across the 4 organisations that the Chief Operating Officers are pulling together. And that very much is about how can we optimise the resources we already have in line with the national UEC plan, not about spending more money to do things. And we heard earlier in terms of what I talked about, the multi-specialty treatment centre, and those sorts of things will form part of that. And then really lastly, 2 bits of bed reconfiguration, just for board and everyone's awareness. The surgical division have successfully reconfigured their beds on the Worcestershire Royal site to improve access to trauma beds that recruit. So that means patients are getting to the right place first time, and Medicine have a plan to do the same for patients who require a stroke bed from the 1st of August. And that's all I want to say, Chair. Thank you.
Very comprehensive, Chris. Thank you. Very broad canvas of stuff going on. Colin asks in the chat box, regarding the ED workforce plan, is this now approved and how quickly will it be implemented?
So we've seen the plan, Colin, in terms of what ED want to do. We have allowed them through the vacancy control process to recruit to some of the posts that they've sought to recruit to. Elements of that plan, though, are linked to the work through the multi-specialty treatment centre, and they'll be finalised as part of the plan to implement that. But it's all within the funding that they, or the money they are already spending. So I don't envisage any problems once we see the plan come forth around how they want to implement that model later this month.
Okay, and Simon asks, are there specific issues affecting ENT and 65 weeks?
I don't think there's anything more specific than I gave in my update, Simon, but there is more work I think we just need to do with the clinical leadership in there in terms of how we can make sure that team are really engaged in delivering the ask around and the expectations for our patients.
Okay, thank you. Julie?
Chris, can I say thank you? Can I take you back to your comments very near the beginning about theatre utilisation being 80%? Now, we all know there's many ways of measuring that, in-session utilisation, numbers of sessions, but that is a huge benefit if we could improve that even by 5%, so it was 85%. So what work is going on to try and really deeply understand the issues there and how we're going to address it?
And Chris, just before you answer, because I was going to ask something similar, in terms of the Diamond patient work that I know you've been looking at, can you feed that into your answer to Julie as well, please?
Yeah, certainly, Chair. So 2 things specifically on 80%. Julie, my update was on ENT's performance. We do know the consultant level utilisation. So then there are individual conversations with the consultants who are on the teams that aren't at 85%. So the top performer is at 92% in terms of the utilisation. And this is capped utilisation, which is the benchmark that we use across all of the GIRF metrics. But the lower performer is just under 80% at 77%. So there is definitely work to do in terms of the case mix. The other bit for me there is the challenge in there around, it's really easy in theory, and I'm not suggesting that's just the way it's happening, that we could have really good utilisation by doing 1 patient on the list, making them last a long time. So the other push for me with the teams is how many cases on those lists are we doing? Because that's the other bit that's important for me. In terms of the work around, I guess it links to the 4 joints on a trauma and orthopaedic list. So what the team's looking at, what we've got available in terms of what we've got lined up for those trauma lists, for those orthopaedic lists. The proposals coming forward to Financial Recovery Board in terms of the work, the specific update, what they're doing. But at the moment, there's 41% of lists that have got 4 joints booked on. More work to do in terms of elements of that particular pathway, but there are more patients ready on standby lists I think there are over 300 patients ready that are Kidderminster suitable, for example, that could be brought in at short notice. And patients lined up to be standbys, and quite often those standbys that are booked on a list are also being done in some specialties, but more work in certain areas, particularly orthopedics around the 4 joints.
I think the other thing, Chris, which we have talked about, and I know you're on, is it's not just the utilisation of the theatres, but it's also the pound notes we get from each theatre list, which we need to ensure we're thinking about to maximise our financial performance as well, which we know isn't good enough. Colleagues, happy to move on? So we'll move on then to quality and safety, and over to you, Sarah and Jules.
I'll go first, Jules. So operational challenges across the patient pathway are continuing to impact on our ability to progress some of our quality priorities. And this includes reducing the rate of infections and reducing the number of falls. We have had extended length of stay of some of our cognitive impaired patients and dementia patients within specialty medicine, which has impacted on the number of falls. However, I am really pleased to say that none of those falls have resulted in severe harm. The number of healthcare required pressure ulcers is continuing to reduce. And we are still making progress on the upward trajectory around gaining compliance with our 25-day complaint target, which has been something that the board is aware we've been working on for the last 12 months. What I do want to advise the board is that we are providing focused support into the ED team due to concerns and triangulated concerns which have been raised around the cleanliness of the department. So there is focused support from both myself and Emma King as the Director of Estates and Facilities in order to make rapid improvements across those areas. And I'll stop there and hand over to Jules.
Thank you, Sarah. Jules?
Thank you, Sarah. Thank you, Chair. So to reassure the board, despite the challenges that obviously Sarah and Chris are alluding to, our overall mortality rates in the trust remain as expected according to our summary hospital level mortality indicators, which is positive news. My colleagues have already alluded to one of our biggest challenge areas currently is our compliance with our fracture neck of femur targets, which the point of those targets is to deliver the best possible care for that group of patients. There is a lot of work going on in that space. We've been reporting for some time now that we haven't been able to meet those targets adequately. So there's a lot of work going in. We've already alluded to bed reconfigurations, theatre utilisation. We've got a workforce review in that area ongoing as well. And there's been a lot of work on the kind of outward end of that pathway that Sarah's been leading on in terms of making sure those patients are able to move smoothly through the system, because patients who have sustained a fractured neck of femur often require ongoing rehabilitation and support once their acute care has been managed. And that's a piece of work that Sarah's been leading on that has been showing benefit. So we're hopeful that we should start to see the improvements in that space that we need to over the next coming weeks and months. There's a huge amount of work going on as well about the integration of our clinical teams with our digital teams, and that talks to sepsis, which we've been reporting on again for some time, implementation of programmes such as Martha's Rule, and the integration of our electronic patient record with things like our deteriorating patient pathway. We've also got a big challenge coming with the implementation of our electronic prescribing module, which is due to go live in the end of summer, early autumn, and so a lot of work in that area to make sure that quality and safety for our patients is improved by those systems, and we're utilising them to the best of our abilities to improve care for our patients.
Okay, thank you, Jules. Thank you, Sarah. Any questions or perspectives on quality and safety? Mine slightly loops back to what Chris was talking about, Chris's area as well. The stroke rehab change that was due to come through in July, is that happening still? Chris?
So, Chair, in terms of our stroke consultants supporting or reaching into community hospitals, it started last week, as the update I've received this morning. I have asked for a bit more of a brief that we'll be able to give a fuller brief to board next time in terms of what that looks like, in terms of what that's meant. But that's what I received this morning and been very welcomed by partners in the Health and Care Trust.
Okay, great. Any other questions to Sarah or Jules? Okay, we'll move on to Ali. The IPR's put together slightly different to the agenda. Ali, over to you.
Thank you. I take the IPR as read, so I'll just focus on the two areas that are our biggest areas of focus really at the moment. The first being sickness absence for our staff. We have seen a further reduction in month on sickness absence, which is really positive, although it should be noted that that's often a seasonal trend as well. So whilst we are showing better than this time last year, we can expect that again obviously to rise as we get towards the autumn and winter flu, cough and cold season. One of the areas that we are focused on is looking at staff mental health and well-being as well. We know that our levels of sickness absence related to individual stress and anxiety remain higher than at pre-pandemic levels. That's not a trend that's unique to Worcestershire. That is a trend across the NHS that we're seeing as well. And we have multiple interventions and support offers available for colleagues that we continue to review and refresh as well to try and understand what we can do to help people in all aspects of their life as well, not just their work life too. The other area that I would like to highlight, which you won't be surprised to hear me talk about, is our temporary staffing management as well. We have reported at previous boards with significant concern around the increased use of medical agency in particular and the high cost agency usage that we are reliant on. Now, some of this is absolutely around increased demand and those escalation areas where we manage people. However, we do know that some of that is around escalating agency rates as well, and some of those contract terms that we need to seek to control. So we've had a real focus on this over the past year, and we are really ramping that up at divisional level now. So we're scrutinising in particular medicine and agency usage and our surgery agency usage, where we know we have that high cost medical agency use. And we are starting to see those reductions now coming to the fore. In particular, I'd really commend the work that colleagues in both of those divisions have done on a line by line basis, looking at each medical agency locum that we are using and what the plan is to stop that usage or convert that usage into substantive recruitment into NHS terms and conditions as well. We are starting to see that progress coming through, and I'm confident from the plans that we're reviewing on a weekly basis that we're going to see continued improvement in that area as well. So in month we are much closer to our target. I think the key for us now is about sustaining that progress and seeing that progress really at the pace that we need as well, because we know that each month that goes by without that substantive member of staff in place or without the transformation that we need in some of our teams in terms of the way we work to work differently to manage that demand, that will continue to place a significant cost pressure on the organisation. And it goes without saying that we would prefer to have NHS staff that are our own staff, looking after our patients on a day-to-day basis rather than a higher turnover of agency staff in that place as well. They were the key points I really wanted to highlight today. Thank you.
Thank you, Ali. Questions and perspectives from colleagues? Karen?
Thank you, Chair. It was specifically on the agency staff, and it's really good to hear the progress that's being made. And as you say, line by line is probably the only way to actually achieve that progress. So well done to the teams on that. But also just to comment, and this. Both cases were nursing, but the principle's still the same. On recent walkabouts, I didn't know they were agency staff, but I happened to talk to in separate departments. two agency staff, both of whom were, and let me phrase this in the correct way, feeling the pinch and the push, I guess, in terms of moving on to trust contracts rather than stay on agency contracts. And, we had quite a good conversation about it and a little bit of a laugh about it, actually. But, it was good to see that people, one particularly was saying, well, the shifts aren't coming through agency. So after X number of years, I'm going to come onto the trust contract. So it is being felt around the department. So it was good to hear that.
I think the other thing, just to any agency workers who might be listening to this, the NHS pension scheme is quite extraordinary. So if you work for an agency, you might be putting away 3% of your own salary, and your employer might be putting away 3% of your salary paid for by them as an employer contribution. In the NHS pension scheme, the NHS put 26% of your salary into your pension. So if you're just looking at the salary, you're missing out the enormous benefit of the pension scheme, which is available to you if you sign up for employment with the NHS. Don't just look at the salary. And Simon?
Thanks, Russell. Ali, this may be one for Jules. I was just looking for an update on where we were with job planning and how that's going, basically, because it's an issue, obviously, that we've talked about a number of times in this forum.
I can very quickly say, sorry.
Yeah. Jules or Ali?
I was going to quickly say that it's progressing absolutely in the right direction, but Jules might want to add some more detail in terms of the progress we can expect to see in the next few weeks.
Thank you, Ali. No, you just confirm, Simon, thank you for the question. Yes, all moving in the right direction. We've got a clear plan, clear strategy as to how we're going to get our job plans compliant. So we're starting to see the improvements in that space. The next stage will be to start to link to get our job plans linked to our annual planning and productivity, because obviously a job plan is a snapshot of what an individual is working. It doesn't necessarily reflect overall productivity across the patch, which is the stage we need to get to next, because obviously that will be the element that we will see the improvements in terms of productivity and getting patients through the system, which is what we need to do.
Thank you. Any other questions or perspectives? Ali and Sarah, I guess, in Justine's absence, I worry for our women's and children's teams that their level of sickness, that over 40% relates to stress and anxiety. Do we feel that we're doing enough to support that team? Clearly there is a particular problem in that team, and I just want to make sure that as my two executive directors in that sort of area, that we feel we're doing enough. Ali, first.
Yeah, so we have had some more detailed conversations with Justine about this. Justine has done a real deep dive in terms of, and the team in midwifery particularly have done a real deep dive in terms of some of the reasons for that absence as well. We're confident it's certainly not all work-related stress, although these triggers are often multifactorial for individuals as well. And there has been particular pastoral support that's been really put in within that area as well. Sarah may want to say more about that, but there have been extra efforts made to make sure that we're wrapping that support around people individually.
Sarah, anything you want to add?
Nothing really. I think Ali's covered it, Chair. That we have lots and lots of conversations, and Justine and both AMRAP as the Director of Nursing for Children's, they are confident that they do have enough support, and as Ali's alluded to, it's actually there is some personal stress there. It isn't all work related. So we're confident it will start to come down shortly. Okay, great. And just on the subject of pastoral support of different natures, I know the chaplaincy team works into you. David, our lead chaplain, has been unwell recently. So David, we send our best wishes to the board for a speedy recovery. So we'll move on then to the money. Neil, we're now sort of a few months in. How are you feeling about the money?
Yeah, thanks, Chair. We're not doing too bad at this point in the year, very early in the year, but we're slightly off track, 0.3 million adverse to plan at this stage. Very much driven by the commentary that we've just heard around additional operational pressures and slippage around some of that CPIP. So I was on the call with Ali earlier around agency, and it was very reassuring to see some of the traction that we're now starting to get in some of that. So good to see. In respect of income, broadly on plan, we're still finalising the contract for 25-26 with our commissioners. We're not out of kilter with anybody else at this point, so probably a week or two more to go to get that ironed out. In terms of employee expenses, you can see there those pressures coming through, the additional capacity that's been put in place, and the slippage around the CPIP is very much driving the overspend in respect of pay. And you can see some of those smaller overspends again in the non-pay. So the position at this point is benefiting from some non-recurrent underspend, some favourable variances that we've got on budget, and some balance sheet releases to the tune of around £1 million. So if we hadn't had those, we'd be in a much worse position. So as I say, that additional focus on the CPIP that we're starting to see come through, and that certainly Stephen's shown an interest in more recently as well, around making sure that we do focus on this and get the traction, is hopefully going to give us some fruit in the months ahead. If you look at the CPIP slide, you'll see that it does come fast at us. Month 6, there is a kick up in respect of the CPIP plans, our savings plans. So we do need to get this on track over the course of the next couple of months. In respect of capital, pleased to say that we've now had the memorandum of understanding through, notifying us that we will get the public dividend capital for the LINAC. So that's progressing, should be completed by the end of the financial year for commissioning early into next financial year. We've had notification of the additional 3 million for critical infrastructure, so around the estates funds for capital expenditure. We are slightly off track in respect of capital against our plan, but if you recall, the board did agree to overcommit the capital plan, so I'm not overly concerned about that at this point. Cash is healthy, and you can see there that our clinical coding team go from strength to strength, and we're now at 100% coding by day 10 of the following month, which is great to see. Just one other thing that I wanted to mention: we've recently submitted our annual cost collection nationally to NHS England. They'll all be consolidated now, passed back out, and of course I'll be reporting that to board in due course. But of course, now we've completed it, we can start to disaggregate some of that information, get it out to the divisions, the specialties, to help support them understand what's driving their cost base, and help support that efficiency, productivity improvement conversation that we really need to get to within the trust. Happy to take any questions, Chair. That's all I wanted to say. Thank you.
Thank you, Neil. So things not easy, but not too far away from where we need them to be. Questions and perspectives to Neil? I really do feel that sort of work that I know Chris is working on with colleagues in terms of theatre productivity and maximising theatre pound notes has got a lot of opportunity for us along with agencies. So let's see how things develop over the next few months. We're running a few minutes behind time, so we'll move on, if there are no questions, onto the safe staffing report for both midwifery and nursing. In Justine's absence, Sarah, do you want to cover both these off first, please?
I will do, Chair. So I'm a poor substitute for Justine, I know, but she has coached me. So on the safe staffing report for maternity, we were safe across all shifts. And although we have talked about sickness being above target, we are now seeing a downward trajectory in sickness, so that the improvements and the support that is going in does seem to be having some impact. We have seen a reduction in turnover and also maternity leave, but that can obviously change very quickly around the mat leave. And the vacancies which we see with our midwife support workers vacancies, they are expected to fill from an event which is taking place in early July. And the number of times that we are having to deploy our community midwives into our acute units has reduced throughout May. However, just really for the board to note that myself and Sue in our maternity safety champion visits is that we have seen our triage unit being under extreme pressure, and this is actually due to the success of our reducing fetal movement campaign, and Justine has now deployed a third midwife to be in the triage service. And I have to say that our concerns, when they were raised, were acted on immediately by that team. And in future papers, Justine will include the bank and the agency usage, just to assure the board of how we are maintaining those safe staffing levels and the good fill rates when the sickness rate is kind of above trust target. So happy to take any questions. Thank you.
Okay, questions and perspectives to Sarah? Okay, back with you, Sarah.
Okay, so this is the nurse staffing report. So staffing paediatrics, neonates and adult inpatient areas maintain safe staffing levels throughout May. And that's despite having all of our escalation areas open. We've had good assurance in our staffing metrics with reduced turnover rates, stable fill rates for all of our nursing and healthcare support worker shifts, and also a decrease in the numbers of staffing incidents that were reported throughout May. And included in the report is that we continue to have a £200,000 cost pressure associated with bank and agency staffing with those unfunded escalation areas. So I'll stop there.
Okay, super. Any questions on safe nursing from colleagues? Okay, well done, Sarah. Thank you. And please pass on our thanks to Justine, I know is helping the Wye Valley team as well going forwards. So we'll move on then to the Green Plan, which we've talked about in different forums before. An incredibly important part of the NHS 10-year plan and our responsibilities as one of the largest employers in the UK. Julian, anything you'd particularly like to pull out of this?
Thank you, Chair. First thing I'd say is I'm presenting this on behalf of Joe Newton, who retired at the end of last month as the Chief Strategy and Sustainability Officer, and this has now passed to me in my remit. It does include the Green Plan, which was considered in great detail at the board workshop last month. For the benefit of members of the public watching, there's a statutory requirement for NHS organisations to have a Green Plan, and our Green Plan requires a refresh for the years 25 to 28 in line with the ICS Green Plan submission that's due at the end of this month. There's been a significant amount of work on green and sustainability since 2022, with active engagement of system partners focusing on place and also sharing best practice. This is in the context of the ICB model blueprint for the future, indicating that green and sustainability should be a provider-led model going forward. So that's something that as a board we need to consider. Highlights of great progress that I'd just like to flag. So far, we've delivered over half the objectives included in the plan, with the rest in progress. We've overachieved the target reduction in our carbon footprint. The target was 25%, and since the years 2019 to 20, we've achieved 34% reduction. And I'd particularly like to flag the removal of the anaesthetic gas nitrous oxide from in a piped manner from trust sites. This has effectively been an industry-leading example that has been incorporated in international policy, and that was led by one of our trust anaesthetists, Dr. Southall. The theme for us to focus on in terms of green sustainability is one of engagement and collaboration, both externally at place level with system-based working, then also internally with creation of green champions and the clinical sustainability subgroups. I would really like to impress on colleagues and board and across the wider organisation that the importance of the green sustainability agenda, because not only does it produce benefits for staff retention and recruitment, also for the health of the population, the environment and future generations, but also absolutely vitally, it helps improve the financial sustainability of the organisation, and therefore needs to be an integral part of our trust strategy and operational delivery going forward. So I'd seek the board's approval for this presented green plan, and also to indicate to the board that with the retirement of Joe Newton, there is a need for us to agree the leadership model for the green sustainability agenda. But given everything I've said, myself and Stephen Coleman are actively looking at that place-based or partnership leadership, pulling on the strengths of different organisations, either between ourselves and colleagues in Herefordshire or at place level within Worcestershire. Thank you, Chair.
No, great body of work, and as you say, lots of partnership working involved in this, Julian. So thanks to Joe and you taking it forwards. Any questions or perspectives to Julian on the green plan? Okay, look forward to seeing that continue to be a cornerstone of our future work. We then move on to the ICB joint forward plan, a behemoth of a document. Julian, anything you particularly like to emphasise on the 89 pages which are attached?
No, I'm sure you'll be pleased that I'll be much briefer with this, but again, for everyone's benefit, this is for information and board approval. This is a refreshed, updated version of the Herefordshire and Worcestershire Joint Forward Plan for the third year. So this is the year 3 of a 5-year Joint Forward Plan. All NHS partner organisations are required to produce the 5-year Joint Forward Plan, outlining how we all contribute to the delivery of the ICS strategy and the joint local health and wellbeing strategies. It should be said that future plans are likely to be impacted by the publication last week of the 10-year new NHS plan, but there was a national statutory requirement for this joint forward plan to be refreshed. And what the weight of the tome includes updates on last year's delivery, refreshed targets for 25-26 for this financial year, but also, if you read the detail, some update on system developments with the Building Sustainable Future programme, and also progress at place level on population health management. Thank you, Chair.
If it was all as simple as planning and a volume of plans, the NHS would be absolutely flying. But I do know how much phenomenal hard work goes on behind the scenes on the production of these documents. But any questions on the ICB Joint Forward Plan? I would just like to say to members of the public, I think we are very lucky in Hereford and Worcester with the ICB team that we have. We work well with them, and we look forward to continuing to work well with them when they cluster with Coventry and Warwickshire. Julian, I think you said we need to approve this as a board. So if you're not happy to approve the ICB joint plan, could you please raise a digital hand? Duly approved. Thank you very much. So we'll move on then to some board committee reports. And I'd like just to thank Julie, Colin and Karen for their leadership of these. Members of the public may not be aware, but the non-executive directors within the NHS do an awful lot of work on subcommittees, hospital visits, supporting staff, mentoring, and are a real asset to us at Worcestershire Acute. So in terms of the quality governance side, which Julie chairs, Julie, anything you'd like to pull out of those minutes?
I think Sarah and Jules have covered most of it today, and I view this as like we set off to climb a mountain and we're getting up, we could start to see the view down a bit. There was a lot of progress reported. We've still got a long way to go, and we did of course present the quality account at the last meeting as well, which has to be submitted every year. So I think we're showing really good signs of progress steadily, and we've still got a lot to do.
Okay, super. Thank you, Julie. Any questions or perspectives on the Quality Governance Committee report from May? Okay, thank you. Julie, just out of completeness, what's your main worry as chair of that committee at the moment?
There's several things. One, a reorganisation can always distract the whole health system and can make staff feel uncertain about themselves. I think there's quite a lot of uncertainty around in the whole health system. Staffing assumes quite a lot of our concern, even though we're a lot better than we were. The news that there'll be a junior doctors' strike today will probably occupy us quite a lot at the next meeting. But we've done such a lot in nursing and midwifery to address those concerns, and it is getting better. So there's a whole range of things that we consider, but when it comes down to it, the things you need to deliver good healthcare are well-trained, high-quality staff, and we've got more and more of those, but we also need the equipment and the kit to do that, and the whole system has been creaking for some time. It's getting better, but we've got a long way to go.
Well said. Thank you, Julie. Move on then to audit and assurance. And Colin.
Thanks, Chair. The content of both the meetings that are referred to has been discussed with board, in that it predominantly relates to the completion and submission of the financial statements for the trust, which has been done. A lot of work and a good effort and achievement within the Finance Directorate. We've had a clean bill of health from the external auditors on the financial statements, clean bill of health effectively from our internal auditors. The external auditors have reduced the number of significant recommendations they've made in their value for money report on our activities from 4 to 2. And I know that Neil would have liked that to have been even better, but I think that's a significant improvement. But we will, of course, continue to monitor that very closely. Nothing else I want to raise.
Thank you very much, Colin, and thank you for your diligence in chairing that committee. Any questions or perspectives on audit and assurance? And then we'll move on to people and culture. Karen.
Thank you, Chair. Similarly with Colin, I mean, the minutes of this meeting have actually been referenced at the last 2 board meetings simply because of sequencing. So with your forbearance, there's 2 additional points I'd just like to pull out. Obviously happy to take any questions on those. But one is the minutes do refer, and we get regular reports both at the committee and at board on freedom to speak up. And it's just to highlight the fact that the National Guardian's Office is one of those sort of arm's length bodies as such that will be impacted and closed by the changes higher up in the NHS. I don't want to speak for Stephen, but I'm not overly concerned by that. I think we've got robust processes in the organisation that will continue regardless of that. So I guess there's some reassurance in our processes there. The other thing I just wanted to mention, simply as a people matter, because I haven't had the opportunity elsewhere, is just to highlight an event I attended last week, celebrating the supported internship programme that we had, where we saw a number of young people complete their 1-year programmes with different challenges in life. It was emotional and a really excellent event, and shows the support and the work that the organisation puts in. Particularly one set of managers talked very highly and openly about how much they'd learned in trying to support people who might have some differences to the norm. And it was a great programme and something we should be very proud of as an organisation.
Thank you, Karen. Any questions or perspectives to Karen? Stephen?
Yeah, just if I can pick up on Karen's point and comment on that, because I think there's the National Guardian's Office, and I think the other one that's received a lot of press is around Health Watch and some of those statutory bodies. I think good organisations do that well anyway, and I think we have to just make sure and have that assurance that listening to our staff, enabling them to speak up is a safe culture anyway. and equally with that is the patient and the public voice in what we do. So I think as we navigate, I think we have to give that assurance that we will continue to do that, because that's what good organisations do, and that's what we should be built on. So I think for all that anxiety, we have to do that, and we've got some really good people working in that space. And I think linking to what Julie said, I don't want them distracted by it. I think we just have to keep them focused on that work they're doing.
Yeah, no, absolutely. Well said, Stephen. But we do recognise, particularly amongst Healthwatch, the very great and important work they've done over a number of years, which is to the benefit of all of our citizens. Okay, colleagues, we'll move on then to the IPC annual report. Again, a bit of a behemoth of a document, infection prevention and control, incredibly important, which we get regular updates on. But Sarah, in terms of this report, anything you'd like to pull out?
The reports for information and for approval to submit and publish on the Trust website, but really it's to offer my assurance to the board that the Trust is fulfilling the statutory requirements under the Health and Social Care Act in relation to infection prevention and control, and that again assurance that robust conversation took place and challenge at the Quality Governance Committee. So I don't feel I need to really draw anything out at this stage at the board, Chair.
Thank you, Sarah. Any questions or perspectives on the safeguarding annual report? Sorry, the IPC report? So if you're not happy to approve, could you raise a digital hand for me, please? Okay, so I think we're then on to the, got all excited, the safeguarding annual report. Again, for approval, Sarah.
Thank you, Chair. So again, this is for approval, and again has been through Quality Governance Committee at the end of June. So again, it's my assurance to the board that we are meeting our regulatory, legal and statutory obligations in relation to safeguarding adults and children and young people, and that we also meet the requirements of the Prevent duty as a specified authority. So I'm happy to take questions, but stop there.
Super, thank you. Any questions or perspectives to Sarah? Okay, great, thank you. If you're not happy to approve the safeguarding annual report, please raise a digital hand. Duly approved, thank you. So we'll move on then to any other business. Any other business, colleagues? I don't think we've had any questions from members of the public. I would just encourage members of the public to ask us anything you'd like on any questions, and we'll endeavour to answer them. The date of the next meeting of this board is the 9th of September, but we do before then have a full board meeting, which I'd strongly encourage members of the public to join us at. It is a very, I think, interesting meeting where we do lots of comparative stuff. So therefore, if there's nothing else to discuss, I suggest, colleagues, we draw this meeting to a close, have a 10-minute break and get back together again at 2:15 for the confidential board. So see you in 10 minutes. Thank you very much. Bye-bye.